During this hour, we will briefly look at how children with congenital adrenal hyperplasia can present and the pathophysiology behind this condition. And then we'll look at how we diagnose this condition. And finally, we'll look in detail about the management of children presenting with classical congenital adrenal hyperplasia. And finally, we will just very briefly look at newborn screening for this condition. Now, let's start with the clinical scenario. Interference. Right, great. Have a look at this case scenario. Imagine that there is a term baby born with a birth weight of 2.8 kilograms who has now presented to the pediatric ward at 1 month of age with poor feeding and vomiting for 1 week duration. So when you examine, the baby has a body weight of 2.5 kilograms at 1 month of age and the length is 53 centimeters. The baby appears dehydrated and lethargic. And they have done some basic investigations. So the capillary blood sugar at the OPD has been 45 milligrams per deciliter. And we have the serum electrolyte report available. The sodium is 125 and the potassium is 6.5. And full blood count and CRP has been sent, but it is still pending. So take a minute and think about this scenario. If you are the medical officer, the doctor attending to this baby, what your thoughts would be. So term baby, birth weight 2.8, presenting at 1 month with poor feeding and vomiting for 1 week duration, progressively worsening, and the baby's weight is now 2.5 kilograms, length is 53, baby is dehydrated and lethargic. You have a slightly low blood sugar level, low sodium, high potassium, and the basic other investigations are pending. Right, so so I'd like you to consider these questions. What is the differential diagnosis or the most likely diagnosis you would consider in this baby? And we have given a very vague presentation, very vague history. What key features would you actively look for to support any of your differential diagnosis or the most likely diagnosis? And how can we confirm this diagnosis? And afterwards, we will next look at the immediate management and the long-term management of such a child. But for now, let's concentrate on this baby and what would be your differential diagnosis. Right, so what would be the most likely diagnosis or the differential diagnosis in this scenario? I think all of you would have thought of congenital adrenal hyperplasia, no, given that it is the topic of the lecture. So salt wasting, but it has to be salt wasting congenital adrenal hyperplasia. But actually in real practice, if this sort of baby presents, what are the other things you may also think about? So you may actually think this is a child with sepsis, right? With poor feeding or with lactation failure, something like that. We have only given that the baby is dehydrated and vomiting and has failure to thrive. So it could be just undernutrition. But there are certain things which point towards a congenital adrenal hyperplasia. That is the birth length. You can appreciate the baby has severe failure to thrive. There is a 300 gram weight loss even at 1 month of age. But the baby's length has increased. Now, usually birth length is 50. So here it's 53. So a long and thin baby. And so any baby with poor feeding and vomiting would probably be dehydrated and lethargic. And that's explained by the low sugar as well. But the sodium is very low and the potassium is pretty high. Even for a newborn, 6.5, you can expect up to 6, but this is 6.5. So this combination is, I think, should suggest that salt-wasting CH is pretty high on the list. However, most babies, if you don't appreciate the birth length and if you don't have the electrolytes available at this point, you may very well be justified about thinking of something like neonatal sepsis and starting your intravenous antibiotics and the other supportive care like intravenous fluids and so on, and managing a blood sugar. What are the other conditions that can cause this condition? So neonatal sepsis can lead to this initial presentation, but when you have a baby with a low sodium and high potassium, what other conditions can lead to dehydration, poor weight loss, low sodium and high potassium? Would anyone like to answer? Other than salt wasting CH, can you think of any other conditions? Okay, so pseudo hypoaldosteronism also can lead to where the aldosterone action receptor is not working. So you can have low sodium, high potassium and dehydration because the child is losing salt, similar to a salt wasting CH. And also renal pathology, right? If you have renal loss of sodium and some renal failure, you can have a dehydrated baby with low sodium and high potassium. So it may not be that straightforward in actual practice when we just see this baby. So that's what I wanted to appreciate, And if we move forward, this is a pretty sick child, so we need to kind of make quick decisions. Right, so now what are the features that would suggest this child is having salt wasting CH rather than the other differential diagnosis? So vomiting and dehydration are features of salt wasting CH, but they can be also manifestations of many more conditions. And they could be associated with failure to thrive. But the features here that you need to pick up are that the linear growth has been preserved or indeed a little bit excessive, and you have to look for hyperpigmentation. Now, if you can appreciate from this picture, this is a baby who may be a normal complexion for a Sri Lankan baby, but it's always good to compare with the parents complexion also, and ask the parents whether the child has been progressively getting darker since birth. A baby who's dark at birth and getting darker day by day. That's a very good sign we see in South Asian skin. So in Caucasian babies, this may not be that obvious, but in our populations, definitely it's a very good sign. And the baby may have hypertension. Again, that's a non-specific sign. And the other key thing is that look at the genitalia of the baby. So this child, now say this is the genitalia of the baby, someone may have thought it's a normal boy child and sent home. But actually, if you consider CH and you look in detail, sometimes you may see that now this is a bifid scrotum, right? And the phallus looks a little small, and if you actually palpate, if this is a child with CH, then you will find that there are no testes in the scrotum. So when a child presents with, failure to thrive and vomiting and, hypoglycemia, sometimes you may forget to look at the genitalia. So it's very, very important to have CH in the back of your mind, especially when you're dealing with young babies who present in a sick state. Okay, so look at the genitalia, look at the skin pigmentation and think about CH. If you think of that, then you will not miss this. Now, so if you take a girl with CH, where the classical 21 hydroxylase deficiency, where they are virilized, you may have only a mild degree. So we have the Prada classification to help us classify the degree of virilization in girls with CH. So if you have Prada stage 1, which is the mildest form, the baby would have more or less normal appearing genitalia with female genitalia with just a little bit of clitoromegaly. So usually the clitoris should be less than 1.2 millimeters. So if it's more than that, some textbooks, Western books says 10 millimeters or 1 centimeter. If it's more than that, then this could be a child with congenital adrenal hyperplasia, especially under those circumstances that we discussed. So look for clitoromegaly. It may be mild. If the child has more significant virilization, or this sort of condition may have been missed by a newborn screening as well, if it's very mild. So the child may actually present to you go home and present to you at 2 weeks of age, perhaps with this condition. But if you have a little bit greater virilization, you will see that you can have posterior labial fusion or even complete labial fusion. So it's like a bifid scrotum, which is kind of the picture you may appreciate in this. And then if you look at the side view, you can see that in the first picture, the urethra and the bladder and the vagina have two separate openings. In the second one, they are kind of joining up together. In the third one, they have joined to form one perineal opening. So this is what you call a single perineal opening. You don't see the urethral opening and the vaginal opening separately. You see one common perineal opening. And with further degrees of virilization, you may actually see the this common urogenital kind of opening coming towards the phallus as well. So in stage 5, that is, you have a very virilized little female baby girl with CH, you may even have a phallus and the urine coming out from the tip, as you can appreciate from the side view. But if you have to palpate this labioscrotal folds, you will find that there is no testis. So sometimes these babies with very severe virilization with salt-facing CH could have been misidentified as a male, though it's a female child. Right. Male children with 21-hydroxylase may have normal appearing genitalia. If you look closely, they may have a longer phallus than normal, maybe about more than 4 centimeters, 4.5 centimeters, but that may you may miss it unless you actively look for that. Right. Then we'll move on. So let's have a little bit of go back and look at the pathophysiology of congenital adrenal hyperplasia. So you will all remember that this is an autosomal recessive condition. However, remember, this is not one genetic condition, right? There are several genetic conditions which can lead to congenital adrenal hyperplasia. So there can be defects in various genes which are involved in the adrenocortical hormone pathway. So the commonest gene to be involved is the gene encoding the 21-hydroxylase enzyme. So the gene which produces 21-hydroxylase enzyme, if it is mutated in both the mother and the father's genes, the paternal chromosome and the maternal chromosome, that autosomal recessive disease will manifest in this baby. So 90% of children with CAH will have problem in their 21-hydroxylase gene. However, when you say congenital adrenal hyperplasia, it can also mean a mutation in the gene encoding the enzyme 11-beta-hydroxylase or 3-beta-hydroxysteroid. So various enzymes. So all these are categorized under the common umbrella of congenital adrenal hyperplasia. The commonest is 21-hydroxylase. Now, when you have a problem, so if you just recall now, the adrenal glands are placed on top of the kidneys and you have the inner medulla and the outer cortex. So we are talking about enzyme problems in the outer cortex. And if you remember your basic histopathology, you have the zona glomerulosa, the zona fasciculata and the zona reticularis, and these three zones produce the three different hormones. So the cortisol, the aldosterone, the cortisol, and the androgens. And the adrenal gland is under the trophic control of ACTH. That means it's adrenocorticotrophic hormone. The ACTH is the hormone which It stimulates cortisol production, and it also maintains the adrenal gland. So if you have in 21 hydroxylase deficiency, when you have low cortisol, because 21 hydroxylase enzyme is necessary for cortisol production and that is blocked, you have low cortisol stimulating the hypothalamus and the pituitary, and there is lack of negative feedback, so the pituitary gland secretes more and more ACTH. And so this makes the adrenal gland grow bigger. So you will have adrenal hyperplasia, hence the name. So most forms of CAH will lead to adrenal hyperplasia. That is why we are categorized as one entity. You can also recall that stress is one of the, so cortisol is a stress response. So when such a child with the cortisol deficiency undergoes a stress, such as maybe develops a mild upper respiratory tract infection or develops a little bit of vomiting, then under those situations, when the adrenal gland cannot respond to the stress, then they will come with what we call adrenal crisis, because they can't withstand the stress. Right. And also, I hope you remember that ACTH is co-secreted with melanocortico-stimulating hormone. So the pituitary, it's a pro-enzyme, pro-hormone, which is broken into ACTH and melanocortico-stimulating hormone. So when there is more and more stimulation on the pituitary with ACTH, you will have co-secretion of melanocortico hormone, stimulating hormone, which will cause the hyperpigmentation in these babies. Right, so let's just recall the hormonal pathway. So I don't want to go through all these in detail, just to give you the basic, overview. But you will recall that cholesterol is taken up into the adrenal cortex, and then it is the precursor of all the adrenal hormones. That is the aldosterone, cortisol, and the adrenal androgens. So you can have those. So star deficiency can lead to CAH, where all three hormones will be reduced. And then you can have 3-beta hydroxysteroid dehydrogenase deficiency. Again, you will have low androgens, low cortisol, and low aldosterone. And then you have the commonest form, the 21 hydroxylase, where the androgenic pathway does not require 21 hydroxylase. So they are, when the precursors accumulate because they can no longer move downstream, they will be shunted to the only pathway which is functioning, which is the aldosterone androgen production pathway. So there will be more androstenedione being converted to testosterone. And this is what causes the virilization we see in 21 hydroxylase deficiency. And further downstream, you have the 11 beta hydroxylase deficiency. There you will have cortisol deficiency. You will actually have reduced aldosterone, but because one of the precursors, deoxycorticosterone, has mineralocorticoid activity, it may lead to hypertension because the precursor itself has mineralocorticoid activity. However, in newborn period, these children can also present with salt wasting because the deoxycorticosterone is not as active as the aldosterone itself. But later they can develop, this is not in all cases, but in some. And then later in life, you will see that they develop hypertension. So like that, you can have varying manifestations. So if you just have a basic overview of this, then you will understand how each enzyme leads to different manifestations. And the other very important thing about CAH is it has a varying severity as well. So even within each enzyme deficiency, so let's consider 21 hydroxylase deficiency. If the enzyme activity is very, very low, then you have the severe salt wasting congenital adrenal hyperplasia. If some enzyme activity, now we are talking about a genetic mutation in the enzyme encoding the hormonal pathway. So if it's 21 hydroxylase enzyme, if there is some activity, then you get a little bit of aldosterone and hydrocortisol being produced. So you may not get salt wasting, but you can have what we call simple virilizing. The salt wasting and the simple virilizing together are called classical congenital adrenal hyperplasia. And what we as pediatricians will see is this form, because this is the more severe forms where they will manifest in childhood. But there can be even less severe defects, mild defects, which lead to partial deficiency of these hormones, where they can, go through childhood and puberty without developing any serious problems. But teenage girls present with oligomenorrhea, hirsutism, and if you examine, they may or may not have clitoromegaly. So this can mimic a polycystic ovarian syndrome in adolescent girl. But if you check the 17-OHP and you stimulate it and see, you will see that it is high. So this is what we call non-classical congenital adrenal hyperplasia. And sometimes women can even present as adults with subfertility due to the high testosterone levels, because you're not treating this condition. So there's a varying severity as well as, so it's a very complex disease condition. And it's good to appreciate that it can have varying, presentations, varying phases. Right. So let's concentrate on 21-hydroxylase deficiency for now. So if you call the little baby who presented with hyponatremia, hyperkalemia, and hypoglycemia, so the basic investigations, the biochemistry we have done, and so if we suspect congenital adrenal hyperplasia, especially if it's a little girl with clitoromegaly, or even if it's a boy with hyperpigmentation, only when we will do, if you are suspecting 21-hydroxylase deficiency, we will send the serum 17-hydroxyprogesterone level. You don't need to do a stimulated, like a synapton test in a child who is, having salt wasting. This is a stimulated situation, so that's enough. So we usually go for a stimulated 17-OHP, that's a synapton test, if it's a milder form where we cannot really, where it's less stimulated, and we may need to do a stimulated sample. Wow. So whatever the form of CH, what we are looking for is the elevated precursor. So if it's 11-beta hydroxylide, we'll be looking at elevated deoxycorticosterone. If it's 3-beta, we'll be looking at elevated DHEAs. But in 21-hydroxylase, the immediate precursor we are looking for is 17-hydroxyprogesterone. And of course, we can look at the end product. So if you look at the serum cortisol level, that should be low. And we can also check the aldosterone level by requesting for a renin-aldosterone ratio. Again, these are tests which take a little bit of time, but it's a good test to do if you have the facilities. And again, if these are also not, if you want further information, you can do the ACTH level, which should be elevated. And in a less severe forms, where the 17-OHP may still be normal if the child is not that, affected, especially in the non-classical forms, then we rely on a stimulated 17-OHP, where we do a synapton test and check the 17-OHP 1 hour after giving synapton, short-acting ACTH, and also the cortisol. So the 17-OHP will go up, while the cortisol will not go up as expected. Right, and in the meantime now, so if you are suspecting a salt wasting CH, the 17-OHP would be adequate as an immediate measure, but we can also do the cortisol and aldosterone levels, which are useful. Then we also request for ultrasound scan of the abdomen and pelvis, where you may, if you see the adrenal hyperplasia, then that really supports your diagnosis, because even the 17-OHP is not available right now at the state sector. And it may not be affordable for many parents to do. So in the meantime, you may, if you have access to a ultrasound radio, consult a radiologist, then please ask them whether they can assist you to help for adrenal hyperplasia. And at the same time, you can look at the internal genitalia and gonads to find out whether it's a girl or a boy. So sometimes you may be surprised, you may be thinking it's a 21-hydroxylase, a girl with 21-hydroxylase, but you may find that it's actually a male with 3 beta. Those things do occur in practice. And if you want, you can do the bone age, but not very helpful in a newborn. And genetics, again, if there is ambiguous genitalia, better to do a karyotype. And of course, specific gene mutation testing can be done, but it's very, very complex. It's not a straightforward test. There are hundreds of mutations which can lead to CAH. So it's not actually very useful except in a research background. Yeah, and then, so how do we manage salt wasting congenital hyperplasia? If we go back to the little baby we saw, firstly, we should remember to take the serum for 17 OHP if it's possible. That's very useful to confirm our diagnosis. But if the baby is in a collapsed state, then our priority is you can take the blood and then immediately you can start on IV hydrocortisone if the baby has all the features. So that can be a life-saving measure. So recently I saw a baby who was 3 months, who had a sodium of 110 and a potassium of 7, was admitted, transferred directly to a pediatric surgical unit in our hospital at LRH from a peripheral hospital with a suspected volvulus, but actually thought to be a baby girl. But actually it was a baby boy with 3 beta with salt wasting crisis. So luckily the surgical team picked it up and referred, and so with a sodium of 110, it can be life-saving at that point. So if you suspect, you can give IV hydrocortisone. The dose we give for little infants is 25 milligrams. Give it as a STAT dose, and then you can give 6.25 6-hourly until the acute condition resolves. So that is 25 STAT and then 25 daily in 4 divided doses, 6-hourly dosing. And of course, you will start resuscitation with 0.9% saline and dextrose if necessary. You can start feeding the child. There is no need to keep milk by mouth, but till the vomiting settles, the child will need resuscitation. And then once the acute stage has settled, we can start on the oral hormone replacement therapy. So what we give is hydrocortisone. In children, we don't give dexamethasone or prednisolone because it impairs growth. So those are given only in very special situations, like if there is testicular rest tissue or after the growth has finished, we can consider those. But in childhood, the treatment is hydrocortisone because it has a short half-life and it has less growth suppressive effects. So in humans, they have found that our hydrocortisone requirement is about 8 to 10 milligrams per meter squared per day. So in children with CAH, we are giving slightly higher doses, what we call supraphysiological doses at 10 to 15 milligrams per meter squared per day. This is because not only are we replacing the absent cortisol, we are also trying to suppress the ACTH drive and suppress the excess androgen production. So we are giving supraphysiological doses, higher doses than we would give a child with Addison's disease, for instance. And remember the hydrocortisone dose, the tablets, usually they come as 10 milligram tablets. Sometimes we have the 5 milligram, but mostly it's a 10 milligram tablet. So the doses that we need for newborn babies are usually pretty small. It could be about 2.5 milligrams twice a day or 1.25 twice a day, something like that. So you will need to liaise with your pharmacy, Indo-pharmacy, and get the little sachets prepared because you simply cannot break a 10 milligram tablet into 1.25 milligrams. So please make sure if you have a baby that you prepare the proper weight sachets from a pharmacy where you can administer the correct dose, and it is usually given as 3 divided doses, right? So first thing in the morning, midday, and then at night, because we want to suppress the androgens throughout the day. So we kind of time them as further apart as possible. Ideally, we can dose 4 times a day, but it's not practical to give it in the middle of the night, and the compliance is very poor. So we usually go for 3 times a day. In very young babies, because the dose is very small, we can start off with twice a day, but as the baby grows and the dose becomes larger, we can go on to 3 times a day. Then, if you have salt wasting CH, these babies will need fludrocortisone. So again, the fludrocortisone tablet is 0.05 milligrams. Very important to remember, not 0.5, it's 0.05 or 50 micrograms. So the usual dose is 1 tablet. And you can go up to 4 tablets, 0.2 milligrams a day if your sodium and potassium is not responding, but it has a long half-life. That is why you give it once a day. So you may take about 48 hours before you see the full action. Now, when you give high-dose IV hydrocortisone at the dose we are prescribing in the acute management, this has adequate mineralocorticoid activity. So high-dose fludrocortisone has mineralocorticoid activity, so you don't have to worry about starting fludrocortisone immediately if it is not accessible in the station you are at that point. So, right, but it's better to, if you have it, it's better to start it early because it has a long half-life, so that when you wean off your hydrocortisone, you have enough fludrocortisone in the system of the baby, the bloodstream. And little babies, before weaning is started, usually during the first 6 months of life, will need oral salt or sodium supplementation as well. But once they start weaning food, then once you start, there is added salt in the weaning food, not added, there is natural salt, so we can wean it off. So we titrate these according to the electrolytes and with the growth of the baby. So this is usually lifelong hormone replacement therapy. The fludrocortisone, over time, some babies, babies are very mineralocorticoid resistant. All of us as babies are mineralocorticoid resistant, but as we grow, we become more mineralocorticoid sensitive. That is why older people develop hypertension as well. I talk about essential hypertension. Same thing, children with CH, sometimes as they get older, you may see on the same dose of oral fludrocortisone, they are developing hypertension, high blood pressure. It's very, very important to monitor blood pressure at least 3 monthly. And if you find that they are developing hypertension, that is over time, the first thing you should do is reduce your fludrocortisone dose, or if you're on a low dose, stop it and see and observe carefully. So they may have now developed adequate mineralocorticoid activity because they are less resistant and may not need. So this distinction between salt wasting and simple virilizing is vague, it's arbitrary, it's a spectrum, and as children age, some of them may change over from a salt wasting kind of phenotype to a more simple virilizing phenotype. Then let's look at the long-term management of classical congenital adrenal hyperplasia. So here we are concentrating on the childhood forms. So both salt wasting and simple virilizing CH need lifelong hydrocortisone. And remember, cortisol is a stress hormone. So anytime the child faces a stress, his or her adrenal gland is not able to produce a response, adequate response. So very important that the family realize that the child needs lifelong hydrocortisone. It is a life-saving medication, and it's essential that there is good, absolutely good compliance with the medication. If the child vomits the drug, then they should repeat it if it is less than half an hour after giving. So it's a safe drug. If you give more, it can become cushingoid over time, but it's generally, it's a more of a replacement therapy at slightly supraphysiological doses. It's very important to talk to the family and tell them this. And they also need to know when to increase the doses, that is the stress dosing. So if a child develops, it's important to tell before you discharge them home, because you don't know in 2-3 days time, the baby may develop a fever from an older sibling or something, right? So it's important to, these are essential information you should tell them. So if a baby develops fever, if it's a newborn, it's better to take to hospital. But if it's as the child ages, we teach them with fever to double or triple the usual doses. And if the child is going for a surgery, it could be a dental extraction or a GA for some procedure, it's very important that they receive IV hydrocortisone if it's a major procedure, and also during major illness. So if the child is vomiting and unable to keep the hydrocortisone in, oral hydrocortisone, they need to take to the nearest hospital and tell the doctors there that the child is on IV hydrocortisone. I tell parents, you have to tell that we have been advised to tell this and that the child needs IV hydrocortisone. I make sure that all parents know the name of the drug, hydrocortisone. That's very important because sometimes in a peripheral hospital, things can go wrong. So there is no excuse for death from adrenal crisis in a child diagnosed with CH, but unfortunately it still does happen. Then, so medical management we have discussed. Then, of course, the girls with CH, if they have virilized genitalia, then we need to discuss surgical management of this virilized genitalia. The other thing that I want to tell you straight away is that it's very important to re-educate this family when the child is old enough to understand. Now, if we start off with a newborn baby and we have told everything, so we'll be dealing very closely with the parents, and then we may forget that the child has never been told about the condition. So usually when they are about maybe 10 years, 9, 10, I think it's a good time to start educating the child as well. So initially, it's important to tell them why they are taking a medication daily and how important it is. And then, again, tell them also the name of the drug, and then to remind them that if they are sick, they need to take a higher dose and how it can, save their lives. That sort of basic stress dosing, I think children should know, because when they are old enough to travel around on their own and so on, well, they should also know the importance of hydrocortisone. And later, especially if they have genital surgery and, virilization, then the girl children, especially around 10, 12, we start talking to them about puberty and, what has happened and why surgery was necessary and so on, because otherwise they are worried about what has happened, but they are usually very reluctant to ask when it's gender-based things, genitalia. And the parents also quite reluctant to kind of discuss these things. Our community, they are not very, comfortable discussing pubertal and gender issues with children. So usually we can take the lead and do this. And before the trial, at 18 or 16 or 18, probably after O-levels or A-levels, we will need to transition them to adult services. At that time also, it's very important to educate the parents and the adolescent again and clarify all their doubts about fertility, genetic, inheritance patterns. All those things must be discussed. And also when we talk about family counseling, remember this is an autosomal recessive disease. So there may be consanguinity in the parents, not all the time, but we do find a higher incidence of consanguinity among our children with CH. And we have also noted that it is higher among the ethnic minority groups in Sri Lanka and among consanguineous marriages. So this is just so that you kind of know the socio-demographic details so that you have a higher vigilance perhaps for CH in these sort of families. And some families have had a previous undiagnosed child neonatal death in a baby with undetected CH. So those are also very important questions to ask in the initial history. Was there consanguinity? Are you from the same village? Have you had previous, babies dying in the very early infancy of unknown causes? Because it may not have been picked up earlier. The other thing is if the parents want to have any other children. So remember, it's autosomal recessive. So we have to talk about their future fertility of the parents. If they are, if they want to have a child, then of course we need to educate them that that's 1 in 4 chance that the next child could also be affected with this condition. Otherwise, we can advocate that they practice some medical, safe contraceptive method, and they make an informed choice when to go for their next child with the necessary information. We do not advocate dexamethasone steroid therapy to the mother to prevent virilization of the female fetus in the antenatal period anymore, because it has been linked to cognitive deficits in later life. So now it's only done on the research basis if you have proper research, under proper research guidelines. Otherwise, it is not done in clinical practice. Right. So we spoke about this. And then how do we monitor these children? So these children need to be monitored at least 3 monthly, more regularly if you see problems. So they need very close monitoring of their growth and puberty. By growth, we mean weight and length. Please measure the length and subsequently the height of these children at every clinic visit and plot it. These two parameters are the really, hard and fast ways where you can pick up excess treatment and under treatment. And so if you now, because the child grows, we will have to titrate the hydrocortisone and fludrocortisone doses. And it's very difficult because we cannot actually, the cortisol assay is not a good assay to titrate. So we rely on a clinical feature. Now, if you are under treating the child, what will happen is there is not enough cortisol, so the ACTH goes up, and so the child will become hyperpigmented because the MSH will also be high. So the child may develop pigmentation. Then if that is the case, then the ACTH stimulates the adrenal gland, then the adrenal pathway is stimulated. So the child may develop virilization. That is, there may be pubic hair growth, there may be axillary hair growth, there may be acne, right? There may be deepening of the voice. All these features can happen in girls and boys. Pigmentation in girls and boys. So with under treatment. And also if the cortisol is inadequate, they may complain of weakness, especially in the morning when your cortisol levels are highest. If we are not giving enough, it's important to ask if they feel weak in the morning, and about postural hypotension if they have inadequate mineralocorticoids. So when they wake up from bed, do they feel dizzy? If so, they may be having postural hypotension and inadequate fludrocortisone or hydrocortisone, right? And the height. So that's why I told you it's very important to measure the height every 3 months and plot it on the centile chart. So because if you're under treating, then the adrenaline androgens will drive growth. So androgens are like during puberty, it drives the puberty growth spurt, it will drive growth. And this height acceleration, this will also increase their bone age. So they will also mature earlier, right? So bone age, I haven't written it here, but bone age is also a good measure of over treatment or under treatment. That is doing a left X-ray of the left wrist and hand. And 17 OHP. Now, unfortunately, we can't do it. Otherwise, do a 17 OHP every 3 monthly at every clinic visit. Tell them to get it done and come. And it can be done at 8 a.m. That is the usual convention. Done at 8 a.m. After they can have the morning dose of cortisol and then do the 8 a.m. 17-hydroxyprogesterone. So we never aim to normalize 17-OHP. We only aim to keep it below 30 nanomoles per liter. Right? So the usual range is about, I think, 5, but we never try to get it to that level, because if we try to get it to that level, we will have to give a higher dose of steroids, which will make them cushingoid and impair their height. Therefore, we have to only kind of titrate it based on your clinical parameters and don't try to normalize 17-hydroxyprogesterone. And if we are over treating, we will find that there is height faltering and weight gain, like cushingoid picture. Children may have, if you're giving too much fludrocortisone, they may develop hypertension, and if you're giving too much hydrocortisone, they might become cushingoid. So look at the face. If they usually develop this puffy cheeks if they are giving too much. So in the absence of 17-OHP, we have to be very, very vigilant about these clinical features. So if we don't manage properly, there will be virilization and advancement of bone age, which in turn will lead to central precocious puberty. And that will lead to final adult height will be short. They'll be short adults. They'll be tall as children, but short as adults, because their bone age advances so quickly. They go into puberty before the normal time and they lose those years of childhood growth. So they lose childhood growth by going into puberty early and fusing their bones. right? So it's very important after about maybe 6-7 years to assess the genitalia of these children for pubertal features as well. So in girls, be conscious of breast budding. Tell the parents if there is breast budding. Tell the children if there is pain, because breast budding usually it starts with painful, pain. So tell them if you ever get these symptoms, please let us know, because this can catch you unaware. It may happen at 6 years, 7 years, and you're not even thinking of it. So it's very important to monitor their bone age, because the bone age will tell you. If the bone age is 10, 11, when a child is 6, 7, then they can develop central precocious puberty. So if you see, and in a boy, the testicular volume. Now both girls and boys may have pubic hair development because of peripheral precocious puberty due to the adrenal androgens. But central precocious puberty will be heralded by breast budding in girls and testicular enlargement in boys. So those are features you have to start looking at pretty early on. And if there is central precocious puberty in girls and boys, we can use GnRH, long-acting GnRH analogs to suppress puberty, and that will help them to improve their final height. So we have quite a few number of children who have, especially from peripheries where they have had problems in coming and getting medication, where they have gone into central precocious puberty, and we have suppressed their puberty for several years and then managed to achieve a much better adult height for them. And the similar thing happens in children with simple virilizing CH, because sometimes, especially boys, if they don't have salt wasting, then they will only be picked up around 5-6 years of age when they present with peripheral precocious puberty. When they have penile enlargement and pubic hair development without testicular growth, that's when we think this is maybe simple virilizing CH in boys. And that point, their bone age, because they have gone for years without cortisol and their androgens have been excessive, their bone age may be very advanced. I remember there was one boy who presented at 4 years, but his bone age was 8 years, and he started puberty very few months later. So we are suppressing him with GnRH analogs. So those things can happen, especially in simple virilizers. And then if we are giving supraphysiological, if we are giving since we are giving supraphysiological doses of corticosteroids over long term, they may develop, especially in adolescence and adulthood, they are more prone to obesity, metabolic syndrome, insulin resistance, type 2 diabetes, osteoporosis. All the side effects of steroid excess can, over time it can develop. So it's very common for adults to have these problems. And finally, if you have a child with virilized, with ambiguous genitalia, then it's a pretty complicated situation. Sometimes there may be issues. These babies may have initially been identified as a different gender. There may be gender misidentity and birth registration may have already occurred. So then there can be very difficult social situations where multidisciplinary care and psychological counseling becomes very important. Then when do we do feminizing surgery for girls with virilized genitalia? So in our center, we usually have been doing early surgery, that is usually around preschool age, maybe between 3 to 5 years, at an age when they are so young that it hopefully will not cause any long term bad memories about painful surgery and that. So at a young age where they'll be hopefully relatively psychologically less affected, because it entails catheterization and then dilatation and so on. Some girls will need repeated dilatation to keep the if vaginoplasty, so it's clitoral reduction, and sometimes vaginoplasty, right, which needs to be done. And then the Western countries are advocating for late surgery, because when you do surgery in a very young child, the clitoris, the nervation of the clitoris may be the thought process, it may be damaged. So it's better to wait until they are, maybe 15, 16, where they can make an informed choice whether they want to live with the clitoromegaly or get it removed. So it's actually cosmetic surgery when it's clitoromegaly. But if it's vaginal, if the vagina is closed, if there's only one opening, then before menstruation, it needs to be done. So it's a tricky, it's a evolving, it's a controversy. And at the moment, we are practicing early surgery, but things may change in the future. Right, and finally, a word about the psychology. So now, because especially girls with 21-hydroxy, girls with virilizing CH, because they are in the fetal life also, because they have less cortisol, their ACTH will lead to adrenal hyperplasia and they will have excess androgens being produced. So this is the one which causes virilization of their genitalia at birth, and at the same time, it can virilize their brain. In the sense that developing brain, the gender kind of identity of an individual, of a fetus, there is some effect on from the fetal testosterone or androgens. So what studies have shown is that during childhood, these girls may be more boyish. They prefer to, climb trees and play with trucks rather than, play with dolls and do the quest. Their maternal instincts are less. And well, their fertility rates are also lower than in the normal female population, probably due to the high androgens. And there is higher risk of even homosexual behavior in girls with CH, because I think the programming which happens due to the excess fetal androgen exposure. However, usually they are brought up as females, and they usually tend to have more female gender identity. They have the reproductive capacity of a female. They have normal ovaries. They have normal uterus. They will go into spontaneous puberty. They will have menstruation, and they are capable of reproduction. Only thing is that sometimes with the androgen excess, they can have subfertility. But it is not always the case. We have one child who has a very strong male identity, who is very, very light at birth and is being brought up as a male. So it's not 100% thing. And again, now the current move is there may be more male identity than we think. But again, these are, evolving problems. So they can have psychosocial problems, but not all the time. And most of the time, this can kind of, go away once puberty starts and the estrogen levels increase. This masculine-like boyish behaviors can sometimes disappear altogether as well. So I talked to you about educating the patient about his or her condition and then transition to adult services. Also, now we can have adrenal cells are usually in the adrenal glands, but we can have some residual adrenal cells in our gonads. And when there is high ACTH, this can lead to what are called adrenal rest tumors. So testicular adrenal rest tumors, that is, the testes can be enlarged because of adrenal, like the adrenal hyperplasia, they have adrenal rest tumors. These are not malignant, they are benign, but they can lead to infertility by compressing the normal testicular tissue. And these people are more prone to sexual problems and subfertility. This is the girls, and also the boys with 3-beta. They will not have spontaneous puberty, so we need to supplement them with testosterone because they are unable to produce testosterone in the 3-beta subtype. Right, then one last slide on newborn screening. So newborn screening for CH is not practiced in all developed countries, but there are arguments for and against it. Now in Sri Lanka, the University of Karapitiya, you can ask for the 17-OHP in the same blood sample as the TSH. When you send the newborn screening, the parents can, I think, pay a little bit of amount and ask for the 17-OHP, which is the newborn screening test for CAH. And the things favoring CAH is that these babies are dying in Sri Lanka. So we have done some studies and shown that about, I think, 7% of the children with CAH who are coming to our clinic have had a sibling who has died in the newborn period undiagnosed. So very, very likely to have had undiagnosed CAH. So children are dying, and it's not only boys, girls are also dying. This is what the research has shown from around the world. And when you start newborn screening, it enables much earlier treatment, and it definitely reduces the mortality and morbidity. However, there are things against it. One is very costly, and there is a high false positive rate. And then some people think that it can be picked up by having a good clinical kind of suspicion before the child will die of CAH. They will have this. So it's very important because we don't have universal newborn screening in Sri Lanka. Very, very important. This is a completely preventable death if it occurs. So we must, I think, as pediatricians, all be conscious about CAH in the absence of newborn screening. Let's not let any child die undiagnosed, because if you think a little and you think of this condition, you may be able to kind of pick it up and save these children. So in summary, so I have a few take-home messages. This is more for the kind of academic purposes. So congenital adrenal hyperplasia can occur due to various enzyme deficiencies involving hormone production in the adrenal cortex. So it's not one enzyme deficiency, it's a complex of diseases which can include one of these enzymes. And the severity of CAH can vary in severity from severe salt wasting forms to mildly symptomatic or even asymptomatic forms. For instance, males with non-classical CAH will be there in the population totally asymptomatic and undetected. And this is not only for 21-hydroxylase, even for 3-beta, 11-beta, this varying severity will occur because of the underlying genetic mutation and the residual enzyme activity. So the presentations of CAH will vary based on whether it's a female or a male who is affected, and what the deficient enzyme is, and how severe this enzyme deficiency is. And that in turn depends on the genetic mutation, because there are many mutations which can lead to these enzyme deficiencies. So the commonest type is 21-hydroxylase deficiency, which 90% of children have, and this very simple CAH, as we know, requires cortisol replacement plus or minus fludrocortisone if it's salt wasting. And even in simple virilizers, we sometimes use fludrocortisone for steroid sparing effect. But the other subtypes, there may be little variation. Right, so for instance, in 3-beta, you will have hypertension and you will not be giving fludrocortisone, but antihypertensives actually. And in 3-beta, the boys will be under-virilized and they will need testosterone supplementation during puberty. And finally, classical congenital adrenal hyperplasia is a childhood disease which requires lifelong care, ideally in a multidisciplinary way with proper transition to adult services. So that's all I have for today. If you have any questions, I'm happy to take them now.